Okay. So people are still joining the call as we speak, but we're going to go ahead and get started. So on behalf of the Community Technical Assistance Center of New York, it's my pleasure to welcome you all to the second part of our school-based mental health series entitled Parents as Agents of Change, Collaboration and Treatment Planning. Before we begin, we want to just address a couple of logistical issues. First, during the course of the webinar, you will be able to chat in your questions or comments by clicking on the chat icon in the top right-hand corner of your webinar window. There may be instances when we'll ask you to chat some responses, but in general, we're going to ask you to, you can give your comments and questions as you go along, but we're going to respond to them at the end. So today's focus in the School-Based Mental Health Series will be parent or caregiver engagement in school-based mental health services. My name is Jim Rodriguez, and I'm joined by Geraldine Burton. Just a word about Geraldine. Geraldine Jerry Burton is a veteran mental health family advocate and a pioneer in mental health family support, the mental health family support movement in New York State. She's a member of Families on the Move of New York, and she works here at the McSilver Institute for on the McSilver Institute's Community Collaborative Board, which focuses on designing, delivering, and testing interventions for poverty-impacted communities. She serves as board president for Families Together in New York State and is one of the original core contributors to the Parent Empowerment Project curriculum, and is a co-facilitator and New York State trainer for the NAMI New York City Metro Family to Family and Home Front programs, among many other hats she wears. My name is Jim Rodriguez. I'm a licensed clinical social worker and psychologist. I currently work in the Step Up program at the McSilver Institute for Poverty Policy and Research. It's an alternative school-based mental health program for high school students from poverty-impacted schools facing numerous challenges to high school graduation. I've previously worked in the school-based mental health program in the Department of Child and Adolescent Psychiatry at New York Presbyterian Hospital. And prior to that, I conducted research on evidence-based treatment for children, as well as in parent engagement in children's mental health services. So our agenda for today is we're going to talk a little bit about family engagement and some of the challenges and barriers for family engagement in children's mental health services. And then we're going to talk about the possibilities, in particular with a focus on school-based mental health clinicians and the possibilities that school-based mental health clinicians have and can play in moving forward on improving children's outcomes. We're going to talk about assessment and treatment planning strategies. And then we're going to review a little handout that is in many ways going to summarize what we talk about on today's webinar. So you may take notes, but at the end, know that most of the stuff that we'll be covering today is going to be in our handout. So we're going to start by talking a little bit about family engagement in children's mental health. We know there are serious problems with attrition in children's mental health services. Prevention and treatment of child mental health problems is an urgent public health priority, but only about 1 in 5 children who need mental health services receive them. Research has shown that attrition rates are associated with parents feeling overwhelmed and highly stressed, which can lead to more severe family problems. We know that research also shows that the highest levels of dropout occur for families with higher levels of psychosocial difficulties and problems involving family dynamics, and that parents who discontinue their child's mental health treatment are more likely to have begun treatment with multiple family problems and reported being both isolated and overwhelmed by the many problems they face. In many ways, keeping children and their caretakers engaged in mental health services at all costs is a public health imperative. More serious problems later in life may be preventable with early intervention, and our work can interrupt negative life trajectories for many people. Even when children may not be making progress, engagement in services can be critical, if for no other reason than to keep families from spiraling into isolation that can make problems worse for the entire family. Although school-based services can help to increase child involvement in therapy simply because they are easily accessible, parent-caregiver engagement can continue to be a problem and might be easily ignored because children are so easily accessible in schools. So talking about parent engagement in school-based mental health services is critically important. What we know about caregiver involvement, of course, including parents and caregivers in treatment, is critical in children's mental health treatment. Caregiver involvement is defined as the active participation of the caregiver in services that is geared towards addressing the needs of the child and family, both within sessions and between sessions. Caregiver involvement it matters because their interactions with their children in the home are critical for their development and for treatment success, and their involvement in therapy is associated with improved child outcomes, and many evidence-based approaches involve working with parents either as the primary focus of therapy, as in many family therapy and parent training approaches, or as critical partners in therapy, as with our trauma and anxiety treatments.
So barriers to engagement, and we know that a lot of times when you're working with families, there are a lot of barriers that prevent you from engaging with families. And so these are the barriers that we feel that more than likely will interfere with that engagement. So we have practical, we have perceptional, we have mental health issues and family ecology, we have cultural barriers, and we have systemic. So with any one or a few of these barriers occurring at any point in time, no wonder engagement can be challenging to do. And one of the things I think that really is an issue is the fact that prior experience, if a family has had negative experiences with mental health services, or someone in their family or a friend, or what they've heard from other parents, it really, really discourages them from treatment. And then we know there's stigma as well. And so when parents have previously sought help and they feel, you know, that they've been highly disrespected, that it really is a predictor of reporting doubts about the use of treatment, and that is a huge barrier. So we have some research findings on barriers to engagement, and as you can see, and the number one is not all barriers are equal. And then, as I said previously, we have these perceptual barriers, stigma, prior negative services, and addressing the perceptual barriers may be more important than focusing only on concrete obstacles. And that can be very that can be huge when you're working with families. So one of the most common reasons caregivers give for dropping out early is that they do not perceive a strong therapeutic relationship with the therapist, and that they are not aligned with the therapist on the goals of treatment. This can happen even despite the best intentions of the therapist. Observational research has shown that therapists tend to over-report the intensity with which they communicate a particular goal or strategy with their clients. Thus, we see that it is very possible for caregivers and therapists to be out of sync with regards to treatment. Therapists sometimes may be doing all the right things, but parents may be only marginally involved, and that's a huge issue. So how do caregivers feel? Focus groups there have been some focus groups that were conducted with clinicians and parents, and that were involved with children with disruptive behavior problems from 6 of the largest community mental health clinics in a large metropolitan county. Participating parents were 50% biological parents, 43% foster, adoptive, and 77% relative. Parents were 21% male and 79% female, and race and ethnicity included 86% white, 7% Hispanic, and 7% African American. 64% were married. So these are just some quotes that, you know, caregivers have revealed about how they feel. And as you can see, at the end it says they feel blamed, low expectations for treatment, and seeing minimal positive outcomes. And it equals what providers label as resistance. And families hear this all the time.
So in addition to some of the barriers that caregivers bring to the relationship, there are also a number of barriers to engagement and to involvement on the part of clinicians and providers and agencies. These include some of the things that we're all very aware of: time constraints, focusing on the protocols for intake and assessment, and essentially the culture of not being used to working in this way, that is, working with families and collaborating with families. And then there's also oftentimes assumptions about the family that they might bring to the relationship, and their perspectives may be skewed. And in my experience working with schools, these are oftentimes attitudes, sort of negative attitudes, that might be associated with how the school sees the parents as well, and sometimes we as clinicians are sort of pulled in that direction. So there are many agency barriers as well.
I just wanted to say also that, you know, I understand and I know, you know, as a family peer advocate and as a parent who has utilized services with my son a few years ago, that paperwork is important, but it should not trump the family experience with what you're doing when you're working with families, because, again, families want to be respected, families want to be heard, and so I just wanted to make that comment.
Yeah. And then there's also a number of other things that practitioners may feel in doing the work with families. There may be just reluctance and anxiety about working with the parents, uncertain about their roles in treatment. There might be some uncertainty. There might be some ambivalence, and ambivalence that derives from conflicts. And again, many of these conflicts, I think, are exacerbated in schools because families may come in with problems that they have with the school that they also bring into the relationship with clinicians. And then others include just compassion fatigue and our own limitations as far as being able to continue to work with families day in and day out. And some school-specific barriers as well. So when you're working in schools, many of the obstacles that we've talked about at the clinician level are also, you could see in most clinics, but there are ones that come up when you're working specifically in schools. And those include things like trying to understand who the client is and being clear about who the client is, meaning, of course, the child is always the client that we're working with, but in working with the families and getting the families involved, having some connection with the teachers, schools oftentimes pulling us in the direction of trying to provide help and assistance, and schools needing our input and consultation around those. So in many ways, the issue of who the client is in school-based services can become a little tricky. Also, the issue of confidentiality and communication, which I'm going to talk about later in terms of how to deal with it, but the issue of confidentiality and communicating children's needs to staff and teachers can be a tricky issue to deal with. And then competing cultures, school and mental health services, the special ed system and mental health services. So many of the kids that we work with are not only receiving services from us, but they might also be in special ed or receiving some special ed services, and trying to figure out how to collaborate in those arenas becomes pretty tricky as well. So we've sort of laid out a number of the obstacles that you might face and the problems with engaging families in school-based mental health services. We want to turn to thinking a little bit about some ways of thinking differently about family engagement. So oftentimes when we work with children in schools, in particular children with social, emotional, and behavioral problems, the support systems that are supposed to be in place to help children overcome and even succeed in school are misaligned. Indeed, this misalignment can be attributed to a number of the different factors that I've been covering, or that we've been covering so far, but also by the severity of the child's problems, the resources available in the school, and limitations placed on clinical services due to the issues that we've talked about before, time constraints, confidentiality issues. However, we do know that, that when those systems are aligned, there can be great and improved outcomes for children. I want to talk a little bit about ecological systems theory. I know many folks are familiar with it, but I think when you're working in a school-based mental health program, they become even more salient and important. So ecological systems theory provides a simple and useful framework for understanding the potential of school-based clinicians to make a significant difference in working with children in schools. So when applied to children's services, ecological systems theory would hold that children encounter different environments throughout their lifespan, and that these systems include the microsystem, the mesosystem, the exosystem, and the macrosystem. We won't go through all of the entire model, but briefly, the self system represents the child and what the child brings to their psychological makeup, their biological makeup, their age, their gender. And then the microsystem represents the direct systems in which the child lives or spends a majority of his or her time, including the family, the schools, with peers, in church, and in the case of children with mental health needs, the mental health system as well. The important thing to remember about the ecological systems theory is that the most influential system, or one of the most influential systems, is the mesosystem. It represents the interconnectedness of microsystems. That is, theoretically, when the critical systems in a child's life are aligned and moving towards the same goal, children do better. In the first part of this school-based mental health series, Dr. Elise Capella provided some great materials for developing collaborative relationships with teachers in schools. Today, we're focusing on engagement with parents, but as school-based clinicians, your relationship with teachers and parents can help to create the kind of interconnected microsystems that help children improve. In my own career working with elementary and secondary schools, I've always seen my role as being a bridge between the child and the school, as well as the school and the family, and between the child and the family as well. Indeed, research has shown that home-school collaboration can have strong effects on a wide variety of behaviors, including classroom behavior, on-task behavior, internalizing and externalizing behaviors, classroom conduct, absenteeism, as well as many academic outcomes. So, and some of the most effective techniques for promoting homeschool collaborations are those that involve two-way communication between the home and the school, such as a homeschool note, which is a fairly common activity that we as school-based clinicians often try to use.
So I'm sure everyone knows about what engagement is, but just to refresh your memory, engagement is about motivating and empowering families to recognize their own needs, strengths, and resources, and to take an active role in changing their life. Engagement is essential in the provider-family relationship from the moment a family is considered for treatment until they are terminated or are discharged. I would even go as far as to say that it's, you know, as soon as you meet that family or and start interacting with them, it starts there as well. So the goals: strong partnership with families equals participation in treatment, and that equals to positive outcomes, and that's what you want, definitely. Strong partnerships with families and participation in treatment are the goals, yet associated with serious challenges to increase positive outcomes?
So one of the things that we think is a helpful tool, at least conceptually, for thinking about parent engagement is based on the unified theory of behavior. So many studies of health-related behaviors have relied on theory in the areas of social and health psychology by researchers like Fishbein, Triandis, and Jaccard. A number of these theorists came together in the early 2000s to try to agree on the critical determinants of health behavior. They were not able to agree fully on the determinants of health behavior, but it did lead to some agreements and the development of a unified theory of behavior. What they basically said is that behavior can be conceptualized along two dimensions. One that pertains to the immediate determinants of health, and one's willingness to engage in behavior. So when you think about the immediate determinants of health, those include many of the things that are needed for someone to perform a particular behavior. And you could apply this model really to any behavior that we think of. In a minute, we're going to apply it to parent engagement and treatment. But for right now, simply, behavior is going to be determined by the skills and knowledge someone has to perform that behavior, habits that they have, breaking habits in some cases and developing new habits to engage in a certain behavior, environmental obstacles, those are many of the things that we often talk about, time and their ability to get there and all of those kinds of things, and priorities, competing priorities. So their ability to engage in a behavior is often impacted by having many other things to do. Those are the immediate determinants of behavior, but what we know is critically important is someone's willingness to engage in a behavior. In other words, what we all know is that most people will not do something unless they want to do something. And so that's the willingness to act. And that is the other dimension of behavior. And so what goes into someone's willingness or intention to engage in a certain behavior? Well, those include the expected value, that is, will this new behavior pay off? What value will it have to me, their expectations? Social norms, what do other people, significant people in the lives of the individual say or think about that behavior? Attitudes and affect, their feelings about it in general, just their negative or positive feelings or emotions, and then their ability, their sense of confidence and self-efficacy in conducting that behavior. So all of these factors play a role in their intention to act. So we have used this unified theory of behavior to think about parents as agents of change in their children's mental health services. So here, we see the unified theory of behavior applied to the idea of parental engagement. So, in order to have parents engaged in services, this model can be applied to any one of the many parental behaviors that are often necessary or required for children's treatment, whether it be signing a consent form, participating in treatment, attending parent collateral sessions or parallel sessions, completing homeschool notes, or following up on behavioral intervention plans. In order to detail how the model can work, I want to apply it to a typical behavior that a clinician might use in a school-based program with a child with externalizing problems. As I mentioned earlier, let's use the completion of a homeschool behavior checklist. Let's look first at the immediate determinants of the behavior. That parent would have to have skills and knowledge to complete that behavior. Their environmental obstacles would have to be addressed. This would lead to many questions, such as, does the parent know how to review the note? Does she know or he know the effective reinforcers for success in using the note, and how to process it if the child does not meet the criteria on that note? And who will review the note? Is the parent home when the child gets home? And then what are other priorities? Might the child get in the way of following through on the note, like what are some other things? Making dinner, taking care of other children in the home. So when we think about all the obstacles that might get in the way of the parent completing a simple thing and following through on a simple thing like a homeschool note, we realize that they may have all these immediate obstacles. If we examine the willingness to engage in this behavior, we would have to ask ourselves another set of questions. Is the parent convinced that this will lead to the intended effect, that it will improve the child's behavior at school or at home? Is she convinced that it will make things easier for her in some way? You'd also have to ask yourself, what do others around him or her say about the use of a homeschool note? Are other people in their lives thinking about or promoting other disciplinary methods? Do significant others feel that this is the most effective way of disciplining or teaching a child new behaviors? And then what are their general feelings about the use of the homeschool note or even mental health services? As Jerry was mentioning earlier, sometimes they've tried things in the past and not had success. They may have tried it in the past and not had a lot of success. So, or they might feel resentful about having to do this on top of the many other things that they have to do, and they may feel like it is the therapist's job to improve the child's behavior, not theirs. All of these factors. And then lastly, their own confidence and their feelings of self-efficacy around disciplining their child. So these are all factors that one would have to think about when you want to engage parents in certain behaviors related to treatment.
Okay, so what does all this mean? So when we apply our parents as agents of change model to factors that contribute to parental involvement in treatment, it gives us pause to rethink how we view lack of involvement or follow through among parents. When translated into resistance, which equals to reduced involvement and positive benefits for child outcome, client resistance associated with low level of clinician liking the client. In other words, how does a therapist develop a collaborative relationship and talk to caregivers so they feel respected and don't feel blamed when involving them in treatment as essential to child change?
So throughout the course of your work with children, there are multiple opportunities to build collaborative relationships with parents and caregivers. These include, of course, the very initial and early context that you have, which often involve an orientation to services. Then, of course, there's assessment. After assessments are conducted, parents or caregivers collaboration continues through the feedback session and through treatment planning and problem-solving specific interventions. We're going to talk a little bit about ways in which you can build collaboration throughout this process. And these are certain processes that we think are critical in building that collaborative relationship with parents. Clarifying roles and needs, especially at the very beginning. Of course, respectful and validating communication. Providing psychoeducation, and we're going to give a slightly different way of thinking about psychoeducation, which includes things like instilling hope. We always feel that motivational interviewing and reflective listening practices are critical in developing that relationship, that collaborative relationships with parents, reframing liberally to decrease blame and failure and hopelessness among parents. And then, very importantly, exploring the barriers, the very many barriers that might exist, both in engaging families in treatment, but also in following through on expectations for treatment and their involvement in treatment, as I suggested earlier with our parents as agents of change model.
So your first contact when you're going to engage a family, so the number one thing is clarifying your role. What can parents expect from you? Then clarify the need. What do you think your child needs? This is asking the parent or caregiver these questions so you can be very clear about, what it is that the parent is or caregiver is expecting. What are the benefits of addressing the need? 3, increase parent investment and efficacy. Affirm them for taking the step to come in. I'm glad, Ms. Burton, that you were able to make it here. I know it probably wasn't easy for you, but we appreciate you showing up. Express your belief that they can take necessary steps. And that's very encouraging for a parent because, again, parents have to go through so much. You never know how much they are stressed, or they may even be depressed. So it's important to, give those words of encouragement. 4, identify potential obstacles, be it personal or practical. How do you feel about this, the diagnosis or the treatment? Do you have any concerns? What will get in the way of your participating? And that's very important as well, because some parents have competing schedules. You may have a child that's involved in basketball or singing in a choir. I know my son had that issue, or going to an after-school program. What do others around you think about treatment? Again, very important. And above all, problem solve and address those barriers. So making sure a first meeting includes, these are very important, discussion of the helping process with families, including family expectations and concerns. Understanding that and letting the families know that they are equal partners in the treatment planning and decision making. Even though some parents feel that, when they come there or when they see you, they a lot of times have in their minds, well, okay, this child is really getting on my last nerves. You are the professional, you fix that child. And we know that that is not the case. Talking with families about barriers to care and help identify resources to overcome those barriers. And then discussions about confidentiality, which we know are very, very important. Because a lot of times I think families feel that when their child is in treatment, the first thing they think about is that if, are you going to call ACS? If they lump everybody together, everybody is a caseworker for ACS. So that having that discussion really alleviates a lot of fear. So these are just some first contact messages that you could share with them. It takes someone very strong to get help. You must be trying your very best. What do you think your child could benefit from? As the parent is the expert on his or her child's needs, and you're the expert on what the services that you're providing. I know what the school said, but what do you think you need? Very important. And I think a lot of times parents and caregivers are not even asked that question. Thank you for helping us to understand more about your child and your family. This will help us to better help you. All of these are very positive, strength-based statements and messages that you can share with a parent or caregiver.
And then, again, some of the things that you could do in terms of developing that collaborative working relationship early on is to really balance the need to obtain intake information with allowing the families and the children to tell their own stories. Now, these, and we say these may sound like obvious suggestions, but they become critically important, especially in this age of managed care. As the workload and time constraints become increasingly scrutinized, these may be more difficult to do, but also incredibly necessary for building that collaborative relationship. The other thing that's important is setting a validating tone, validating parents for their concerns, validating parents for everything from their frustrations, their difficulties, their frustrations with the system, with the school. So in many ways, these are the ways in which we can join with parents by validating their perspective. And these are just some examples of statements that you can make to help them and validate their efforts, even when they may not be efforts that you necessarily agree with or that might be the best for the child. But oftentimes, being able to validate the valid, as we often say in DBT language, becomes critically important.
So if your first contact is by phone, these are just some tips that we wanted to share with you that would be very helpful for the parent or caregiver. Be sure the caller has the date and time of the appointment, as well as the directions, if applicable. Be sure the caller understands that he or she needs to bring past reports, insurance card, identification, list of medications, etc. Explain the timeline of the first appointment, orient them to the clinic, paperwork, questions, topics for the first appointment. And a follow-up phone call, and if they don't have a phone that works, or maybe send them something in the mail as a reminder. These are all very, very important. Again, families are dealing with a lot of things, and sometimes, you know, they don't remember, even though, you know, and if that's the case with some of the families that you work with, maybe suggestions that they have a calendar where they can write these things down, because it's very important. And you want to work collaboratively and in partnership with them to make sure that that treatment process, especially the first one, the first contact, is a positive one. So we want to identify and problem solve around barriers to help seeking. So some of the things you can explore: potential barriers families may face in obtaining ongoing services. Addressing concrete barriers families may face, such as time limitations and transportation challenges, and recognizing perceptual barriers families may face. All of these are very important. There's some other types of, again, as I said previously, previous negative experiences with helping professionals, discouraged by others to seek professional help, differences in race or ethnicity between the interviewer and the client, families' experiences with racism and its impact on their willingness to receive services from a system need to be carefully explored. All of those are very important. So identifying attitudes about previous mental health care experiences. This is always critical, but will be particularly critical if there has been past bad experiences with the mental health system, and in the context of school-based mental health services, it can be even more difficult if the parent has had a history of poor relations with the school. And we know that that happens a lot. You know, sometimes parents get targeted because they are seen as being resistant, or, you know, you're making phone calls and they're ignoring your calls, or when they come to the school for one, maybe not to see you, but for whatever reason, they see you, they avoid you, and, you know, all these things happen. So you have to really explore those things.
And for this reason, confidentiality in schools becomes even more critical, simply because in schools, there are going to be limitations on confidentiality that might be reached. So meaning that in a school setting, in a school-based mental health program, as opposed to coming into a clinic, it is often difficult to protect a child's confidentiality or family's confidentiality simply because they may be going to your office. They may be going to the clinic in the school and seen doing that. So confidentiality, and then oftentimes I should say because the referrals may come from the school is aware that they're going to get an evaluation. So it's always important to review with both the client and the parent the limits of confidentiality, and even to emphasize that according to HIPAA, the school is not technically even supposed to know that the student is a client. This should lead to a much more detailed discussion about confidentiality. So, of course, covering with the child as the primary client confidentiality and the limits, but also with the parents. The importance of what information to provide to the school and what not. And that will become clear as we move forward with some of the other difficult issues that may come up at times. Okay. So strategies to promote inclusion in treatment. This is going to be moving into sort of treatment planning and assessment. So oftentimes we need to realize that even though treatment and assessment is clear to us and the process is clear to us, it is not clear to parents. We simply show this slide to give you an idea that for parents, the idea of assessment, DSM-5, how you make a proper diagnosis and how you lay out treatment plans for children is clear to us, but not to them. This is what our process can look like and feel like to parents if we're not clear. So, some strategies for gathering information. Of course, you always use judicious questioning. You ask a lot of questions, but try to utilize information that's already gathered. And be mindful of how difficult it might be for parents, again, especially those who've been through the system before. And then be creative in how you gather your information. And gathering information across providers. In schools, the fact that you're in the school and have easy access to teachers who may have a lot of information about kids to provide makes it easier to access some of that information, but at the same time also creates some of those difficulties around confidentiality. So having those discussions with parents also becomes important for the assessment process. And sometimes inviting someone else into the sessions to help provide information can be helpful. A family advocate like Jerry and others who are in that professional role.
So with psychoeducation, and this is a crucial component across treatment approaches and diagnosis, and there are 4 core areas. 1 is instilling hope and reducing blame. 2, orienting to services. 3, information on the illness. And 4, information on treatment options. Overcoming provider and client barriers to do this consistently. And I have to say that it's very helpful when you can share that information with a parent or caregiver. And again, as it says, it's information on the illness, because sometimes parents just want to know what it is. They want a name for what it is, for the behaviors that the child is exhibiting. And it really alleviates a lot of their fears. Okay, so we have some key messages to instill hope. And some of them are no-fault problem, correct this idea, okay. Take care of yourself, that's very important, self-care. There's no right way for everyone, you know, there's no one-size-fits-all. Together we can make real progress. What is your role, what is my role, and the child's role? Change takes time. A lot of times when I work with families, I just let them know there's light at the end of the tunnel, you know, and it is a process. You're not alone. Your child's problems have been experienced by others. Very encouraging and instilling hope. Dangerous situations need immediate attention. Self-harm and harm to others and property. Ask questions, and that's important that we have a shared understanding. It's a back and forth. Important to reach out to and to use your social support and be hopeful. We can develop a plan that can make things better. So building mental health literacy. Again, going back to orientation to services. How does accessing services work at your agency? What are the services? What is therapy? Who will the family be seeing to access the services? Because a lot of times when families come in, maybe there's somebody that's, you know, doing the intake, and that's not the person. So being clear about who it is that's doing it. Who do they contact with any questions or concerns, and what resources are given to the family, and what is the role of the therapist, the caregiver, and the child? Is all this communicated to the family when you see them?
So, a lot of what we're talking about right now has to do with sort of gathering information. And providing feedback often becomes an important part of the treatment planning process. And we like to think about it as the what you're doing and the how. So the what is the diagnosis? What does it mean? Being clear on it. What are the symptoms? But one of the most important questions that I often ask to parents in terms of the how and the process to be empowering is, does this diagnosis make sense? Is it, and being practical, is this a working diagnosis versus a relatively clear diagnosis? Oftentimes, we have to be clear with parents whether we're sure about things, and oftentimes we do have working diagnoses. Sometimes with difficult to diagnose children, we do have to take more time with the evaluation. These are all things that are incredibly important to communicate to the parents. Be sensitive. Knowing you have to understand that you're diagnosing a child with a chronic condition. I think back to instances when we've been doing parent training and remembering a parent whose child was diagnosed with ADHD, which we all know is a fairly common diagnosis, but she talked about the depression that she went through when her child was diagnosed with ADHD. Being hopeful, as we kind of discussed already, and being collaborative. How can we include the school? And this becomes incredibly important. We also have ACAP Facts for Family available. And ACAP Facts for Family is a website that you can go to that provides information for families about various diagnoses that is easily available in the public domain, and you can get it in a variety of languages. It's available in Spanish, it's available in Chinese, and I believe a number of other languages as well.
And it's in layman's terms, which is very helpful for families as well.
So the other thing that's important is in treatment planning is creating choice. So meeting families where they are. So oftentimes treatment planning means getting families to agree to participate in treatment at a certain level. And this involves gaining an understanding of the family's needs. So when we're considering treatment options and choice, it's important for a strong working relationship that you provide parents and caregivers with choice about treatment options. This is especially important when parents will be expected to participate in treatment more regularly, whether it be coming in for parent training sessions or being part of family therapy sessions or completing parallel sessions. Always help them overcome these obstacles that they may face. It's really important and critical to understand those up front and anticipate obstacles and try to address them. So sometimes you may push parents to really identify those obstacles beforehand. Having discussions about the limitations of services with co-pays and limits on the number of visits. This might become even more important in our time of managed care. And discussing the pros and cons of participating and in treatment, and then providing alternative choices if they're not able to participate. So sometimes having the discussion about whether your treatment is a good choice and whether you're able to make changes or whether they're able to have to follow up on other choices, and then helping them and following up and getting those.
So managing parent-school conflict. Parents often need help negotiating with other systems, for example, the school. This can sometimes be a source of an anxiety for the clinician, resulting in some of the avoidance that we discussed earlier. However, this can also be an opportunity for the clinician to demonstrate their ability to help and effectively solve problems. It can be supportive and educational for the parent as well.
And this is where the school-based mental health clinician can play an incredible role in building those bridges between the family and the parent and the school. So some of the things that we want to alert you to in terms of troubleshooting problems that might come up between the parent and the school when those difficulties come up. Some of the things include trying to stay neutral. Although we have to advocate on behalf of our clients, neutrality can simply be defined as helping them understand the school's perspective. When interacting with the school on behalf of the parent and the child, and even with the parent, it is imperative to revisit the conversation about confidentiality in the school and what can or cannot be or should not be shared. Okay. Some other points that are really important in terms of helping families deal with school issues is, encouraging the parent to meet directly with the teacher or the administrator, focusing, helping them and preparing them to focus the discussion on one or two issues and sticking to that issue before moving to other ones, providing teachers and schools with information about the child's disability. Again, this is why the importance of having a conversation about confidentiality becomes important. And encouraging the parent to bring someone, whether it be a friend, an advocate, or you as the clinician. And then going in there with an idea of what the child needs to improve their educational situation. And these are all suggestions that can help when you do have thorny discussions with the school about a child's progress. And lastly, we want to end with a little bit of home visiting. And this is, although you may not engage in home visits, we're just going to go through very quickly a few points that we think are important with regards to home visits. And also because in the future, in managed care, there may be more opportunities for billing for home visits that are not there now. So visiting families in their homes can be an opportunity to obviously learn things about the family, as well as conducting some of the interventions that you do work on with the family. And home visiting can provide a number of different advantages. And these are just some of them. But it gives you some more information. It allows you to align with the parents more, to work with them more on a much deeper level, but also in many ways deepen your relationship with them. And it is incredibly important to be respectful of parents when you're doing home visits. That means the basics, being there when you say you're going to be there. You're going there as a guest, so be observant of their traditions. And then ask the family where they would like to meet when they're in the home, whether it's the kitchen or the living room. Asking the family how they would like to introduce yourself to another guest if they arrive, or someone else who's not expected. Being considerate of their personal effects. And these are just a number of other suggestions that we think help to make home visits more successful in building a working relationship with your family. And those you can keep and put into and keep by your desk and be prepared for when you're doing home visits. So with all this work on family engagement, we are not very much enamored of developing new training manuals. This is just a little cartoon that we like to show on the disadvantages of having manuals. But we do believe that having some information and having some primers and some easily available information can help. So we put together this family engagement at a glance, which basically summarizes much of what we've talked about on this webinar. It includes some of the early contacts and some of the points that you have that we made about what you want to focus on in your early contacts. It has our Parents as Agents of Change model in there. We also include some of the points that we made about psychoeducation and how you build hope with families, how to orient them, and what are the questions that you want to ask when you're orienting families to your services, and some of the points we made about feedback and how to give feedback, both the what you want to tell them and the how you want to tell them. And we also have some other helpful reminders. First contact, your first contact with families on the phone, bridging the home-school gap that can happen sometimes, talking about confidentiality. So with that said, this will be available on our website, as will the slides from today's webinar. So you will be able to access those slides and our handout. And I just want to end, and then we'll have questions and address those quickly. But yes, well, before I do that, very quickly, these are some upcoming webinars that we have. I'll leave that up in case you're interested. And this is our contact information if you want to follow up with us. So I'm just going to look here at some of the questions that have come up during the course of this talk. So first, one question that came up. I would like to ask about parents with mental health diagnoses and treatment of their own and the additional barriers that they may add. In many ways, my perspective, and I'll let Jerry answer from her as well, but my perspective is that if you are building strong relationships, many times, even though you're not treating them, and that may make developing a strong relationship with parents more difficult, many of the strategies and the ideas that we've talked about in here with regards to building a strong relationship are meant to do just that, are meant to sort of establish a working relationship with parents, and we hope that by doing that, and in many cases you might see that interviewing and listening to parents and just joining with them and validating with them can help parents, in particular parents with their own mental health histories. But of course, the other piece to that is helping parents find the services that they may need as well.
No, I totally agree, and I think that the huge takeaway is just meeting them where they are, wherever they are, and do that active listening, and I think that will help. And just, again, the steps that we said, like being respectful and encouraging and validating, I think all of those things are helpful as well. Absolutely.
Okay. Another question, and please feel free to send your comments and questions in at this point. Another question that came in, do parents need to know or give consent if student is receiving treatment in school? Absolutely. If you are a licensed clinic with New York State, all the rules that apply to any clinic, outpatient clinic at a hospital or a community-based program apply in the schools as well. Again, depending on your program, but as I said, if you are a licensed clinic with New York State, all the rules apply. So students, parents still do need to give consent for students receiving services for treatment in the schools. The program that I work in currently is actually more of a prevention program, so we don't do typical psychiatric evaluations and assessments. So there are other types of programs in schools that don't require that, but if you're a licensed clinic, you do. Another question that just popped up, what about parents who refuse treatment for a student we know is suicidal and wants counseling? Well, obviously that gets into, and I'm glad you raised that issue, because earlier as we were talking about providing parents with choice, if you are providing parents with choice, oftentimes that choice may not be as clear-cut if a child is suicidal. If a child is suicidal, you have to be aware of, and if you've done the assessment and have identified suicidality as a possible problem, and the parent does not want treatment, then you have to, in some cases, discuss it with your supervisor, and if necessary, report to ACS, because that could be considered, medical neglect. And obviously that would create serious problems with regards to your relationship with the parent, and we don't have time to talk about it on this call, but oftentimes when you are making those kinds of referrals to ACS if necessary, that would be part of the conversation and I will say that that doesn't necessarily have to be a relationship killer in many ways, but that is something that you would have to address with parents.
Yeah, I was just going to say, and it's important that it is addressed, definitely. So.
Yeah. Any other questions?
Somebody wanted to know the website also. Okay.
How to engage with parents when child is mandated for services by the school. Again, as I said, I also want to point out that, again, many of the strategies that we've talked about are intended to try to build that relationship with parents. So we do hope that by focusing on the needs, by validating parents, by trying to get as much their perspective on these issues, that is a way of dealing with. In many ways, we could have talked about in this webinar motivational interviewing strategies for parent engagement, because so much of what we talk about is really about motivational interviewing focused on the parent. But yes, I mean, dealing with mandated clients can always be thorny. But as we've talked about, the better relationship you can build with, and we hope that many of the strategies we've talked about will help. We have a comment about this being a good refresher. And I'm glad you said that, because we realize that many of the points that we've made here may sound obvious, but there are things that we forget, or there are things that we fail to do. So what we hope, not only by this webinar, but by our handout, what I would like you all to do is make a copy of that handout and have it on your desk available to always remind you of those things that you need to do along the way to build a collaborative relationship with the parents of the children you work with.
Also, it says, what do you recommend for parents who feel that it is the child who has the problem and feel that they do not need to be involved? I think in a situation like that, you just have to, again, engage that parent or caregiver and just let them know that it's important that they're involved. You need their input for certain behaviors, you know, observations and so forth and so on. And also, I believe it helps the child as well to know that you are genuinely sorry about that, want to be involved and you care about them. So, you know, Jim, you can add to that.
And I will say, and then I'll leave it here, as I was saying earlier, the important thing is keeping the child and the family engaged.
Right.
And what I mean by that is that if that means rolling with that, negotiating with the parent what they possibly can do, even if it's in the most minimal way to participate in treatment, obviously just by giving their consent, but whatever they can maintain in terms of connections with you. It may not be optimal given your treatment plan and given what you're trying to do, but you can increase it. But it's more important that they remain engaged with us than to be out there isolated and alone with these problems. And I think that's why I said earlier that keeping families and children engaged in services at any cost is a public health imperative. And this is one of the things that I mean by at any cost. It may mean at the cost of full and optimal participation on the part of parents.
And that goes back to also, sorry, Jim, when we were talking previously about what is the parent's role, what is the therapist's role, what is the child's role, helping them to understand, because a lot of them, this may be their first time, this may be, maybe they had, again, previous negative experience, but just letting them know that, okay, this is what we need to do. I need you involved in this process. We are working collaboratively and in partnership together so the treatment process can be a positive one. Just reiterating that for that parent or caregiver and letting them know that, you know, this is what is going to help this treatment process move smoothly. You know, we may have some bumps in the road, however, this is what we need to do in order for the treatment process to be a positive one.
So thank you all for your participation in this webinar, we look forward to you joining us on other webinars, and keep an ear out for future school-based mental health webinars. Thank you.
Thank you.